was wonderful. Very interesting. With 7724517. 30 is going to at 9 Eastern Time. Very interesting. Was it good or was it bad? Bad. The coffee, however, is wonderful. The coffee, however, is Brazilian. Very good from Brazil.
Hello, this is Dr. Deepta. Hello. Hi, can you hear me?
Yeah, we can hear you, Dr.
Can you hear me? Yeah, okay. Can you unmute all the speakers, please?
Yeah, I'm doing one by one. You can start the meeting.
All right. So it's 8:33. We're going to start the meeting now. Hello, everyone. I'm Dr. Seema Arora, Chair Board of Trustees of National AAPI. I welcome you all to yet another teleconference in the AAPI COVID. This series we started about a few weeks ago, and we've been having twice a week teleconferences. And many of you have attended previous teleconferences and found them very useful. So thank you all for joining. Today we have some more updates for you and some excellent speakers. So we have some very useful topics and some very practical topics. Before we start, I would like to make a disclaimer on behalf of AAPI, and I will read this out to you. So this series of AAPI COVID-19 teleconferences is for information purposes only and should not be considered as medical or financial advice. AAPI has no liability as to how this is interpreted or used, and is not liable for any losses, damages, or results that may be caused directly, indirectly, or incidentally. Please refer to CDC website for recent changes and updates. So at this point, I would like to invite Dr. Lokesh Edara, who is one of the founders of this series. And then after that, we will invite AAPI President, Dr. Suresh Reddy, if he's already joined, to open the conference. So Dr. Edara, if you're here, please say a few
I'm
words.
here, Seema. Thank you. And go ahead and have Suresh talk. Thank you.
Okay. Dr. Suresh Reddy, are you here? All right. Looks like he's not joined yet, so we can have him talk a little later. So we will go with our first speaker. That is Dr. Saraswati Mupama, who is a pulmonary critical care and sleep medicine specialist at Beth Israel Leahy Health in Massachusetts. Dr. Saraswati will give you some updates in pulmonary critical care and what is happening in the hospitals in ICU setting. So, Saraswati, you can take over, please.
Is she
Dr. Mupama?
Is she is unmuted or no?
Vijaya, can you please unmute her?
I think I texted her number. Maybe Deepta said it. 718. Let me do. No, 718.
She's unmuted.
15838. Thank you. Saraswati.
Hi, can you hear me?
Yeah, go ahead, ma'am.
Okay. Because I'm the first speaker, I want to take the opportunity to thank AAPI, President Dr. Suresh Reddy, the leadership, and moderators Dr. Lokesh Edara and Dr. Seema Arora. And I also want to thank the co-speakers to share the virtual stage and all audiences for spending their dinner time with us today. And just like many of you these days, my new norm has become having dinner with the COVID meeting literally almost every night. I've been given 5 minutes. The first 3.5 minutes, I'm going to talk about the caveats in pulmonary and critical care. And the last 1.5 minutes, I'm going to be talking about just my personal experiences, what's going on. So the newer symptoms, signs and symptoms, as all of us know by now, it's the fever, respiratory symptoms, and GI symptoms. But what is new? Pleuritic chest pain is also known to be one of the symptoms. So any of your patients come with a pleuritic chest pain or palpitations and chest tightness, that's something we need to keep in mind. And along with the loss of smell and taste and AFib and heart ailments, neurological symptoms, they're also coming up now, altered mental status. And there's something called an acute necrotizing encephalopathy. It's a rare complication of influenza and viral infections. But in other parts of the world, in Italy and other parts of the world, they're starting neuro-COVID units because they're seeing more patients with strokes and seizures and encephalitis-like syndrome. I think there were one or two cases, one in Florida and one in Henryford as well with these neurological symptoms. So that's something I wanted to lay emphasis on. And moving on to the comorbidities, risk factors related to my specialty, the two big things are vaping and cigarette smoking. So 1 in 3 Americans, high school kids, they have the tobacco product in them in the previous 30 days. And vaping, as we know, will cause E-Valley, that's called the vapor-associated lung injury, and it's also known to cause cognitive dysfunctions. And whether the younger patient population for being also affected, is it a factor? Vaping is this a factor or not? We still don't know, but there is a possibility. That's what we think it could. That could also be related to the vaping could be related to this severity in the younger age population, and so is cigarette smoking as well. And this is a great opportunity for you all to ask your patients to quit smoking. Next would be coming to the chest X-ray findings. Chest X-ray, that's the major thing that we do. That's the first initial diagnostic testing we do radiologically. And for ease of decontamination, usually the portable chest X-ray units are being preferred. And 69 to 70% usually have an abnormal chest X-ray at the initial time of admission. But more than 70% or 80%, close to 80%, they can have abnormalities on the chest X-ray at some time during the hospitalization. And the findings, as the timeline is moving from 8 days to around 12 days after the symptom onset, it gets even more, we can find more of these symptoms going on the chest X-ray. And what do you find on the chest X-ray? Airspace opacities, consolidation, ground glass opacities. They could be bilateral, they could be peripheral. And a few of the studies have also shown that there's a lower zone predominance in these chest X-ray findings. Coming to the CAT scan findings, what do we find in the chest? Ground glass opacities, you can see. Crazy paving appearances. Those are the septal thickenings between the lobes, within the lobe and between the lobes. It's called the interlobular and intralobular septal thickenings. We can see them too. Airspace consolidations, you can see them. And you can also have bronchovalvular vascular thickenings in these lesions. And few of them have actually also shown traction bronchiectasis. That's another finding we see. And these symptoms, and patients can also present with pneumonia or pneumonic changes on their CAT scans. And they can have peripheral distribution. Those are the main typical CAT scan findings that we're finding. Atypical CAT scan findings, pleural effusions, yes, but it's really very small percentage can have pleural effusions. And mediastinal adenopathy, that's also a very small presentation. And tree in bud appearance, those are all atypical CAT scan findings. And next, moving on to the ICU part of it, we don't wait to intubate the patients. Early intubation is preferred. That's one. And once they're intubated, right, and they're on the ventilators, because most of the patients are going to be on ventilators, there's going to be a shortage. So there's a bit going on between states now. I was listening to the radio in the evening. There's a bit going on between states about who can get the maximum number of ventilators for their own state. And FEMA is also getting involved in that. Because there's going to be a shortage of ventilators, they're looking into something called BiPAP with a helmet mask. where the patients can use the BiPAPs, but with the helmet mask, because that way the aerosolization spread would be minimized. And the other caveat is also regarding the prone positioning. We know that prone positioning helps a lot in hyperoxygenation in patients who are in their ARDS stages, but prone positioning in non-intubated patients is something the hospitals here are doing as well, just to help with the oxygenation. So those are the main caveats I have to do with the pulmonary and critical care part of it. The other 1.5 minutes, what I wanted to talk about was my own personal experiences. And what happens is recently, I do televisits, and my pulmonary patients, anybody, if they're coughing, my immediate knee-jerk reflex is just moving away from, just staying far away from anybody who's coughing. And even if I cough, everybody looks at me. I think the fear is set into all of us that we lost even the freedom to cough freely. And it's the fear that really has engulfed us. But we do know beyond the fear, there's a lot of hope and faith that we'll pass this and this will be behind us, and all this will pass. So I wanted to make the point that emotional support is also very, very important during this pandemic which is going on. If you look at the ICU nurses, ICU staff, and the ER physicians, usually they sit together and have food and they interact with each other, and there's so much of close communication going on within these units. But that is so much lacking now, and it's really a sad thing. And even the families who are in the ICU, the families are not able to go and visit them. They have a lot of restrictions. And we are trying to do our best, having a video call inside and having a phone outside, and the families can see the patients who are in the ICU. But it's a really, really sad situation. So I just wanted to throw some light on that aspect as well. Thank you.
Seema, go ahead and into the next speaker. Hello, can you hear me?
I can hear you.
Yeah, we can hear you, Dr. Dara.
Oh, okay. So I don't know what happened to Seema. Let's next speaker is Dr. Drumal Shah, family physician, chief medical information officer, compassionate medical president, Great Boston Society of Physician Entrepreneurs, president, Indian Medical Association of New England, innovation combat of COVID-19 pandemic. Dr. Shah, please go ahead, sir. 5 minutes. Is Dr. Shah is unmuted? Hello? Hello?
Dr. Drumal Shah is still muted. I can see him on his screen.
What's the last 4 numbers of Dr. Shah? Anyone know? I don't know what happened.
Yes, I'm going to.
No,
I'm unmuted, but my video, I cannot start my video because it says the host.
Don't worry about video, Amit.
9994.
Last number.
The last 4, Dr. Drumal Shah.
You have the phone number?
617.
Okay.
365.
9994.
99. That's right.
Did you find Vijay? Okay, let's start. Can we take another speaker while Dr. Shah is coming? Dr. Sanjeev Arora is Project ECHO COVID-19 response. I'm sure ECHO is well known all over the world. He's a director at ECHO Institute, distinguished reagent professor of medicine, University of New Mexico School of Medicine, New Mexico. Dr. Arora, please go ahead, sir.
Well, thank you very much. If the host can let me put on the video, that would be helpful because I can show you some information. But mostly, thank you very much for this opportunity to present to all of you. And the ECHO project is a way to democratize the implementation of best practices for underserved people all over the world. And our goal is to help 1 billion people by the year 2025. So currently we are working in 153 countries, and the model works based on 4 key principles. The first is we use technology to leverage expertise, and the project was started in 2003 to tackle the problem of hepatitis C. And the challenge we were facing at that time was that out of 28,000 people in New Mexico, where I live, in the Southwest United States, there were only 1,500 patients that had been treated. And the treatment was somewhat complex with injections and pills of interferon and ribavirin. So no primary care doctor was willing to treat the patients, and there was an 8-month wait to see me. And people were driving hundreds of miles 12 times to see me, and there was an 8-month wait to see me. So I developed the ECHO model with the idea that I would train primary care clinicians to become specialists in hepatitis C treatment. And we set up 21 sites and we trained them. And the way we do training is we call it iterative guided practice. So every week, all 21 of these primary care clinicians would join me on a Zoom-like conference by video and present patients which were de-identified to each other and to me and my team at the university. And we would help them and they would help each other. We call this all teach, all learn, and every doctor would present 1 case a week and learn on about 10 a week. And what we showed in our publications, that over the course of a year, they became great experts. And the wait in my clinic fell down from 8 months to 2 weeks. And we published in the New England Journal of Medicine that the results that these prison doctors and primary care doctors were getting were identical to university specialists. After we demonstrated this in hepatitis C, the next step for us was to actually show that, that this could be applied for lots of other diseases.
No, I cannot do that.
And we first tried it for substance use disorders, then mental health disorders. And currently we do ECHO project. We have 800 networks in the world. We have trained about 380 universities in the world to do ECHO. And we have about 100,000 clinicians who are being mentored on ECHO in 153 countries. Now, what has happened since COVID-19?
I cannot. If they're doing something, I cannot.
In the last 2 weeks or so, we have transformed the entire global ECHO networks into a COVID response system. And in 2 weeks, we have, in our interactive models and our technology, we have trained close to 120,000 doctors in the world on the best practices in COVID-19. And now all our work in COVID-19 is fundamentally around 2 major strategic areas. The first is in these countries, we amplify what we call the public health response, which is how to do testing, how to build lab capacity, how to implement social distance guidelines, how to assess, how to quarantine.
People mute who are not talking. Too much background noise. Now go ahead, sir.
Yes, and so thank you for that comment of muting. That would be helpful for everyone. If you could mute.
Before?
Amit, mute please. Go ahead, sir.
Yeah, so I think, so what happens is that in the COVID-19 response, we are trying to do 2 things. Amplify the public health response, which has to do with training public health officials all over the world on best practices in public health of the kind I talked about, how to scale up testing, manufacture.
Mute, Amit. Go ahead, sir.
The second key major strategic area that we work in is amplifying the care response. So this in primary care settings, this means training primary care clinicians on how to see patients remotely by phone, how to protect yourself through personal protective equipment, what to do if you don't have enough PPE, if you have to clean personal protective equipment, how to do it, how to do infection control in your respective clinics, etc. Whereas, how to manage patients. On the inpatient settings, our ECHO projects train doctors on how to manage inpatients, when to send to the ICU, how to do ventilators, for example, in settings like in India, where we have now trained more than 80,000 doctors. In inpatient settings, we train them what to do when there is no ventilator, or how would you split a ventilator to be shared between 3 patients? What would be the role of CPAP and a helmet? What if you had to use umbo bags because you didn't have any of this technology? What would that look like? And of course, treatments. So we are very, very active in the COVID-19 space. We plan to train about 1 million doctors over the next 2 months, mostly working in India and Southern Hemisphere. Because what we anticipate is going to happen in the Northern Hemisphere, the COVID-19 cases might start declining with the onset of summer. Whereas on June 21st, the Southern Hemisphere of the world will hit winter. And as you probably are aware, lots of cases are rising in South Africa, also in Latin America. And so we are currently putting a lot of emphasis on those countries to prepare their public health systems and also amplify the care response, which is not just training doctors, because many of these places don't have doctors, training nurses, community health workers, physician assistants, and lay workers. And we also have large programs to train what we call first responders. And essentially, to show you for the people, essentially what we anticipate, and we hope that some of you will join our networks. We have many in the United States in partnership with CDC and the Assistant Secretary of Emergency Response. And if any of you need to reach out to me, please email me and we can help you get connected to our networks. And thank you again to AAPI and Dr. Seema Arora for this opportunity to present on this network. And Dr. Suresh Reddy.
Thank you, Dr. Sanjeev Arora. Is Dr. Tharmal Shah is back?
Can anybody hear me? Am I unmuted? I'm just trying to figure out if I'm unmuted. Can you hear me?
Yes.
Tharmal Shah, are you there?
Yeah, I'm here. Can you guys hear me?
I already introduced. Go ahead, Dr. Shah.
Let me introduce Dr. Tharmal Shah. He's a family practitioner and also Chief Information Officer at Compass Medical. He's President of Greater Boston Society of Physicians of Entrepreneurs and President of Iman. Go ahead, Tharmal.
Thank you, Seema, for kind introduction, and thank you all for joining the conference today. I really want to highlight a key subject which is usually not familiar to general clinical community. Practice innovation and what can innovation do in the times of pandemic. So one of the major consequences of COVID-19 pandemic has truly showed how frail and or weak our healthcare system could be at times when we need expedited solutions and services. So just to give you guys a little bit of background, penicillin as a drug was discovered in, I believe, sometime in 1928, but it was not really available for general public use till 1945. And for those of you who know the history more than me, 1918 was the Spanish flu. So little over 100 years ago, we went through something similar to COVID-19. Another example is stethoscope was created in 1816 and in 1851. So after 20 plus years, it really went from one-sided to two-sided to become binaural. So why am I sharing this? The main reason for that and COVID-19 is innovation is a mindset. It's not a product or a solution. Innovation has to do with the mindset of your leaders, yourself, your patients, the society. And the definition of innovation is satisfying the user's current or future wants and needs by turning an idea into a product of service with speed and urgency. And you have to do all of that with minimal amount of resources and costs. So how do you actually do all of that in COVID-19 when we hear, for example, in Massachusetts, our first case was diagnosed in, first fatality was discovered in March 13th, Friday. And for those of you who are tracking the data, the clock 43 days starts for your healthcare capacity to exhaust. So how do you take that 43 days of time and innovate, redesign, deploy resources, what you have, and come up with the new resources, and how do you battle COVID-19? So without going over too much detail, I would like to just share a few examples with you guys in terms of what practice innovation could mean. Telehealth is a small component. Today, practice redesign is happening all across the country, where everyone is deploying physical models of infection control in one way or the other, even in physiatry office or behavioral health office. Whether you are an orthopedic surgeon trying to suit up and help the patient in ICU because your calling requires that from your academic medical center or your employer or yourself, or you are a behavioral health therapist who is doing group counseling for general public in these times of vulnerability. All of this practice redesign needs resources. From google.com COVID-19 website to all the way to CDC website, every one of the innovators, entrepreneurs, and educators, everyone is coming together. One of the best example I can share, which is near and dear to us in Massachusetts, is Massachusetts Medical Society. They have created a COVID-19 page where every resource, local and national, is in one page. Whether you are a physician looking for a wellness resource or you are a telehealth vendor selection you want to look at, you don't have to do this alone. The bottom line is the innovation is a mindset. As we all change our mindset as a clinician and a healthcare system and bunch of healthcare professionals who are at the front line fighting this battle, we have to build the team around us. Even the executives of the hospital who are MBA or some other degree doesn't have MD behind their name, they are also vulnerable and afraid. They need your help. Granted, it's not going to be always that you will have that culture in every organization. There will be a lot of tug of war. But one of the best examples I can share with you is from MedStar in Washington. They deployed what we call medical bunker in the early March. So March 3rd or 10th is when MedStar put 25 of their physical locations in one medical bunker and started telehealth completely in preparation for COVID-19, which happened before CDC announcement and the national emergency announcement. So there are organizations and providers who are doing innovations rapidly, and we can all do it in our own practice. And with that, I would like to just give you guys all the resources in the slides with all the links after the conference, and AAPI leadership will be more than happy to share those with you. Thank you, and stay safe and stay healthy.
Thank you, Dr. Shah. That was very informative. Moving on to our next speaker, Dr. Amit Chakravarti, who is a urologist in private practice and is also Vice Chair of AAPI Board of Trustees. He is going to give you some important information how practices can financially survive at this time. Please go ahead, Dr. Chakravarti.
Is Amit on unmute?
Yeah, I'm unmuted, right? Can you hear me?
Yeah, we're here.
Yes.
Thank you.
Okay. So thank you very much again for allowing me to present this. This has been very near and dear to me because I am a solo practicing urologist. I've just got a nurse practitioner, and in a relatively small town where we don't have too many providers in urology. So the whole nation, and thank you very much for AAPI, Suresh, Seema, and Lokesh for allowing me to present this. Let me start by saying that we know that whole nation has been gripped with fear and anxiety about this, and fueled by a lot of WhatsApp media speculation and stuff like that. And this shouldn't be taken lightly, but in my personal opinion, we as healthcare providers should remain calm and instill some confidence in our patients and support staff. Now is not the time to panic, and that's exactly what I try to tell people what we can do. Now, this will vary from state to state, practice to practice, and whether you're a primary care, private practicing physician or a hospital employed physician. I'm actually going to speak mainly from the perspective of financial stability, or how you can survive financially as a private practicing physician. I'm not an expert, but this is what I'm going to cover today. First thing I'm going to cover is if you want to keep working, how to keep working safely in your office practice. What are the safety guidelines? And if you're a surgeon, what do you do for your surgery? Your elective surgery, emergency surgery, etc. We'll cover that. And number two, I'll also cover how to keep your practice afloat, how to get emergency loans, Medicare accelerated payments, and loan deferral. So that having said, let me start. We are physicians. We have a dilemma whether to close our practice or whether to continue. We are here in not only financially here, we also have an obligation to our patients, especially if you're in a situation like I am, where I have to, there are not too many urologists to serve the public. So we decided, had an office meeting, and we decided that we'll keep open and keep open very safely. Now, here's what I do to keep my office open, and some of this absolutely may be elementary. Some of you might be doing this already, but I put this as a blog and send it to people, and people actually appreciate it. So I'm going to reiterate it here. So first is that we all know we'll need to limit our patients, the ones who only need to be sealed. The other patients may be rescheduled, maybe a month or 6 weeks away. Of course, if your state is in lockdown, then you might have to send them to ER and only rely on telemedicine. Number two, have your receptionist call your next day scheduled patients and have them read a scripted note asking them about dry cough, fever, shortness of breath, or have them come in contact with anybody who has had these symptoms. And if so, reschedule the appointment and have them contact the primary care physician or flu clinic. And let everybody know, even in your after hours message, that if anybody wants to cancel their appointments without even giving you that 24 or 48 hours notice, you will waive any no-show fees. There will be no no-show fees, and if they cancel without notice. Number three is you need to rapidly incorporate telemedicine in your practice. This is absolutely urgent. We all know that Medicare has relaxed guidelines about telemedicine. You can actually see your established patients and bill them exactly as if you're seeing them in the office. And to a certain extent, you can also see new patients, as in if the patients have been seen more than, these patients have been one of your patients, but have been seen more than 3 months ago, 3 years ago, you can bill new patient code even without seeing them. Obviously, you cannot bill level 4 or level 5. You'll have to bill it with level 2 or level 3, but you can still see these new patients. So telemedicine is very important, and your EHR or billing service may have already in place, and they may have it. There are a lot of other telemedicine services which are out there. You can look for that and find one which is more compatible to you. I selected one which has got texting capabilities, so that rather than email capabilities, not many telemedicine companies have texting capabilities, which is very important because people carry their phones all the time, not necessarily look at their emails. But the problem which I have, because I cater to an older population, a lot of my patients still have flip phones. So what you need to tell them that, hey, listen, do you have a daughter or a granddaughter who can come over to your house they obviously come and check up on you. Can they come during that 15 minutes where we have scheduled the telemedicine, and my office staff call them beforehand and have them download the Zoom, and this is the one which I'm using is Zoom based. Or if the patient is has an iPhone, we can FaceTime them, or if they have an iPad, we can Skype them, because Medicare, the government has relaxed the HIPAA stringent rules for doing teleconferences.
Thank you, Amit.
Number 4. My 5 minutes are over?
Yeah, you can go ahead 1 more minute.
Oh my God! No, I thought it was only. I just started. Okay, it's been. I've got about 2.5 minutes left. But anyway,
No.
I'm going to just go ahead. So all the other things: hand sanitizer, wipe every exam room, encourage patients to come without any accompanying persons, safety masks, etc., etc. And above all, instill discipline and sense of detail to your support staff. On surgery, this is very important. If you're a surgeon, follow hospital and your society guidelines. Otherwise, you may be liable both ways. In other words, if your society says that you can do these kind of surgeries and you cannot do these kind of surgeries, you may have to follow them. And again, your hospital guidelines. Emails I send to my patients, I'm not going to cover that because I'm going to go fast. What I'm asking about, the other financial steps are negotiate with your lenders and monthly payments like mortgage, equipment, car rent, credit cards, malpractice society dues. You can negotiate with them. I have done that, and they have deferred it for 90 days. For your disposable, like Botox, in-office BPH procedures, you can ask them for a 90-day billing. See whether you can get a low-interest loan line of credit. And everybody knows about the payment, the patient payment, the PPP, which you can apply and keep your employees still. You can pay the employees for two months, and all those are there in my website in a blog. Medicare accelerated payment is something which Trump has just now started, where you can apply. You can ask for 3 months payment of your average Medicare bills. You can ask for that. You'll get it straight in your website. That's called Medicare accelerated payments. And the CARES program, with who basically you can get your IRS things without any, you can waive your required minimum distributions for 2020, and you can defer any distribution penalty if you take it early. So those are the things which you can do to continue doing that. And I can just read one quote, which I can say that we'll get through this crisis, the economy will recover, and for those don't look at the shaky ground, look at the horizon ahead. This will just be over in 2 or 3 months. And anybody else who wants to learn a little bit more, my website is AAPI.com, and click on blog, and all the blogs have got all different things which I just covered very rapidly today are there in a point-wise manner. Again, it's AmitAPI.com. Go to blog, the last thing, and that will give you a summary of all which I have discussed today. Thank you again for your
Thank you, Amit. Thank you very much for the information. Our next speaker is Dr. Sanjeev Chopra. He's the professor of medicine at Harvard Medical School and editor-in-chief for Hepatology Up to Date. Dr. Sanjeev Chopra is going to talk about how we can recalibrate our life in these difficult times. Dr. Sanjeev Chopra, please. Dr. Chopra, are you there?
Is she unmuted? Is he unmuted? You have the number?
Vijaya, can you unmute him? Yes, enter the number.
Okay.
Okay, so Dr. Chopra?
Okay, can you hear me now?
Yes,
Yes.
sir.
Okay, thank you so very much for inviting me to share with you some reflections during these very trying times. Everyone I've heard so far has both informed and inspired me, and I think many of us are recalibrating our work, our personal life, reflecting on what's important and what's not priority. A pandemic like this, something we have never seen in our lives, brings out the best and the worst in us. And I want to focus on what we can do to reach out to other people. All the work you're doing is so inspiring, but in order for you to continue to do that, you have to be grounded. You have to be anchored. You have to find solace and comfort in yourself. So the first thing I would suggest to you is that find some time for silence, whether it is prayer or meditation. You might ask, what's the difference between prayer and meditation? In prayer, we speak to God. In meditation, God speaks to us. I have a saying, you should meditate once a day, and if you don't have time to do that, you should meditate twice a day, because then we really need it. Number two, let's reach out to family and friends on a regular basis. And what we now have the ability with Zoom to actually reach out literally every day to friends and family and talk about positive things and talk about all the good that's being done, all the amazing philanthropic work that's being done, the use of artificial intelligence, 3D printers, innovation as we heard about. Dyson is developing ventilators. 3D printing will help us. Artificial intelligence will help us. It will help us even in designing vaccines. And we need to have an effective vaccine. Of course, that will likely take a year or 15 months. But we'll also find out that there are novel antiviral agents that already exist and can help us treat this deadly virus. It's also a time where many of us have some bonus time. Multiple meetings, travel, talks, keynotes, etc. Society meetings are being canceled or postponed. So make use of that time. I think everyone hearing this, I say this when I travel as a visiting professor to junior faculty and fellows, I say every one of you, first I ask the question, have you written a book? And most of the time the answer is no. Some people have written a book or more. And I say each one of you has at least one book in you. You have a story to tell. So launch it. And it's amazing, I come back and a year later, 3 of the faculty at a prominent university will write to me and say, Sanjeev, you may not remember, you mentioned it, we've written a book. You know, these days you can self-publish through Amazon, or I can connect you to a literary agent in New York. Each one of you, if you're passionate, has a TED Talk in you. So now's the time to jot down some notes and prepare that TED Talk. Some of us have given TED Talks, and it's a way to reach out to so many different people. This is the opportunity to say something that we can only regret on our deathbed. This, in fact, is a nurse who interviewed 1,000 people in hospice and said, what are your greatest regrets in life? And one of them was, I didn't say I love you as often as I should have. So reach out, say I love you, recalibrate your life. One of the things we can do first thing in the morning, even if we are working at home, is to spring out of bed, go into the shower, put on some music, sing a song, drink your favorite cup of coffee, dress up, not in your pajamas, dress up and go to your study or your computer and start to work. So there are many things we can do to reach out. I would urge the leadership of AAPI to connect with foundations like the America-India Foundation. We have migrant laborers who are walking 500 miles to get to their homes. We have people in slums. How can we even talk about distance learning? But are there other things we can do to help during this amazing crisis? So reach out. I think I looked it up the other day. There are more than 2,000 billionaires in the world. How many of them have stepped up during this crisis? Very few. And if they do, they often tend to be people from the United States, maybe people from Australia, some other countries. It's not an ethos or culture in India, I regret to say it, for people to be philanthropic. India's second richest person, Asim Premji, few months ago went from second richest billionaire in India to 17th richest. And it's because he donated another $7 or $8 billion to charitable causes. He has donated $21 billion. Maybe we put out an ad through AAPI in the Times of India and challenge the billionaires in India to step up, to help with vaccine development, to help foster the ECHO project, to help with food distribution, clean water, to help the migrant laborers, and so on. I think we need to throw the gauntlet out there. This is an opportunity that we should avail of and do in a brazen and bold and audacious way. So I gave a talk some time ago on philanthropy, and somebody asked me the definition of philanthropy, and it's a very simple definition. Philanthropy is love for humanity. The only true nation is humanity. We're doing work in this country, we can do work in India, but we can also help out people in other parts of the world. And I think AAPI is poised with amazing leadership and with amazing breadth of membership to ask people to contribute to something that resonates for them. So I'll stop speaking here and happy to take any questions or comments.
Thank you, Dr. Chopra. That was very rejuvenating. For those who don't know, Dr. Sanjeev Chopra and Dr. Deepak Chopra are brothers and also authors of many bestseller books. So lastly, I would like to invite Dr. Deepika, an infectious disease specialist who has been helping us throughout with with ID updates during our series. So just very quickly, a few minutes, Dr. Deepika, if you can update us with the recent developments in ID.
Sure. I'm an infectious disease physician, was practicing in New York area, and I think I have memories of the initial days of HIV when we had similar issues of people panicking and spread and things like that. But of course, this is a very, very different virus, which the contact is by droplets. And I just want to talk about the statistics and then some method of transmission, what is new, and then the antibody response. And a few new things which have come up in the last few weeks. You're all aware of the total cases. Now we are up to more for 200,000. And the New York is the epicenter. And epicenter is by definition is the one which has the highest number of cases in a concentrated area. And New York is now up to 82 or 85,000 cases. And almost all of the cases, all of the states have cases except for one state which does not have case. Even Hawaii has the cases and Alaska has cases. And it is of the infectious diseases and other, including Anthony Fauci's opinion, is that now the entire country should be on a stay-at-home policy for several weeks, but the White House authorities have not approved that, and I think that has contributed to the spread of the cases. So as a physician group, we are in the forefront of this, and we are the ones who are who would have the high liability of getting the infection and also the cause and the prognosis and the mortality and morbidity associated with that. We should be asking for it because it has been shown that is the best way to control the diseases. So, and we should continue to advocate for that. And I just want to talk about what is new on the diagnosis area. The diagnosis area, we have now the new antibody testing, which has been FDA approved. It is now being tested in many of the big centers, and it's not available yet, I think, on the regular laboratory. In about a week or two, it will come up. What it tests is that it gives you total antibody testing. It tests IgM and IgG, both for SARS-CoV-2. And by looking at the literature of what has been happening in Wuhan, it looks like the total 93% of the people develop both IgG and IgM. And IgM is seen in 82%, and IgG is seen in 64%. The reason for the low number in IgG is many of them, they could not process a specimen. People have left hospital or their follow-up is lost. What is interesting is that IgG, which is the acute antibody, which develops by about 4 to 5 days, and IgM develops usually by about the 14th day. So by about 11 to 14 days, you will see, by 11 days, all of them have IgM. 14 and after, all of them have IgG. So if you could combine, because the initial PCR testing is negative in about 30 to 40% of people if you test them below first 7 days. So if you could combine the PCR testing, which what we do with the nasopharyngeal, and with the IgG test, you get a 98% within the first 7 days. So I think this is the combination. We'll be able to pick up the patients both with IgM and PCR. So that gives us early detection and isolation of the patients at home or quarantining the people, and with that, reduction of contacts and more incidents. And one of the other interesting thing is, it was reported when I was listening to the conference at Mass General, there are no, they were not able to do any testing in the mice model, and they were looking for the transgenic mice, which is difficult sometimes to get it. And then the primate, non-human primate was the one which was available. But there's a lovely article which has been reported saying that the golden Syrian hamster seems to be an excellent model for COVID-2, and it shows the same pathology like what is seen in the humans, and with the infectious particles going through the animals, going through the weight loss, anorexia, then going through the necrotic lung changes, and then recovery. Most of the animals recover because, as you all know, that the COVID-2 is very specific for each animal, and the hamsters do get better. What was interesting was the hamsters did recover by giving immunoglobulins. So it looks like we could prevent progressive disease by giving convalescent serum, which is what the IgG, the immunoglobulin IgG, IVIG can be given, which is also seen in about 3 or 4 cases in China, where they've reported that by giving IVIG in also moderate to severe ill patients, they were able to recover. So there is a role for IVIG. One of the things I would request our physician audience is that if you know of any of your patients who are COVID-19 positive or had diseases who have recovered, ask them to contact different agencies. We're all looking for volunteers to collect for IV serum and to develop the IVIG as a passive immunity. We are now lacking materials for that. So that is another one I would like to talk about. And then the interesting thing is what happens to our immune system. Why do we have such a acute response and progressive lung findings with the destruction of the lung tissue and the huge cytokine reaction? Usually you would see a nice T8 cell response and the killer cell response whenever there is a viral disease. And in this particular case, the severe lymphopenia, what we see is represented by all depression of all T cells. You have depression of T cells, T4 helper cells, T8 cells, as well as natural killer cells. This is rather unusual because the T8 and the natural killer cells are the ones which help with the recovery of the virus. So the T4, T8 ratio is totally suppressed. But as the patients recover, the T8 response goes up, and so the ratio is slowly comes up. So that seems to be one we could probably use as a prognostic factor. And the other one I want to talk about is pregnancy, which is interesting in several ways, because we have asked people to stay home. And I'm not saying it is a humorous factor, but it is natural tendency for people to, at this point, you know, it's a normal human function to have sex. So it is going to be very hard to ask couples and others not to have sex. So we may see pregnancy happening through this period of COVID infection. So we should be ready for it. So the Chinese literature has a few cases they've reported. They have about 2 or 3 people who have gone through full-term pregnancy and delivered. And what is interesting is that the newborns were negative for COVID virus, and they did not see the virus in the amniotic fluid or in the newborn. So that's only about 2 cases, if I'm not mistaken. That is the only 2 cases which has been reported. And also, there are about 4 or 5 cases of pregnancy they watched over during the initial month to the midterm and to the late pregnancy. And they did not see any stillbirths or any spontaneous abortions. I think, again, it is it is heartening news for us to hear that, because normally any viral infection, especially when there is a high fever, there's febrile mortality to the children. So I think these 2 are important for us to see that. And then I want to talk about
I think your time, I will ask that, madam. We'll ask the question.
Very good.
Thank you so much.
We should move on to Q&A session. I would like to invite AAPI President, Dr. Suresh Reddy, to say a few words.
Hello, thank you. Can everybody hear me?
Yeah.
Yeah. First of all, I would like to thank all the AAPI team. Seema Arora organized this today, and Deepta Nedunchezian is the chair of AAPI COVID Task Force Committee, and Lokesh Idara is the co-chair. Thank you all for organizing. We have organized several of these, and the audience varied anywhere from 300 to 500 each time. And today is very close to my heart, because this is my home team from Boston. And I would like to especially thank Dr. Saraswati Muppana, a good friend, and Drumil Shah, another good friend. And I would like to thank Dr. Sanjeev Arora, the director of ECHO Institute. AAPI recently signed an MOU with ECHO, and Dr. Sanjeev Arora has dedicated himself to this ECHO project, which is doing amazing projects in USA and also in India. Looking forward to work with you more, sir. Thank you again for joining. And Amit, my friend, and he's always energetic, and wish I have his energy. And thank you, Amit, for joining. And special thanks to my mentor from Boston. He was one of my mentors when I was at Harvard faculty in Boston for almost a decade. And Dr. Chopra is an amazing speaker. And he was the first Indian dean for a School of Continued Education at Harvard Medical School. And I have listened to him, heard his lectures several times, but every time you hear, there is always something new. And thank you, Dr. Chopra for joining us, and thank you all other speakers if I left anybody else, and thank you audience for joining. And I would like to also invite you personally. This Saturday we are doing, this is a series of like 7th or 8th such teleconferences. We have another conference coming on Saturday. It's a special conference because we have, it's a Southeast Asian conference. This is the first time AAPI is partnering with the Pakistan and Bangladesh faculty. So we three will be bringing speakers from all 3 countries, and we'll invite all the audience from all these countries. So this is going to be a special thing. And afterwards, we would also like to invite at some point our own Sanjay Gupta from CNN and maybe Dr. Fauci. We are trying several ways to bring them. If hopefully we'll have that maybe next week or sometime. Thank you, Seema and Lokesh, for giving me this opportunity. Thank you all.
Okay, Seema, one good question. Thank you, Suresh.
Thank you, Suresh. So now we're going to open up for Q&A session, and you can text your questions to Dr. Lokesh Dara at 269-209-7235 or to me 781-504-7266. So I already have a few questions. Lokesh, do you have any? Do you want to go ahead or?
Yeah, I can have a question. What is the risk of your family if you're working as a pulmonary physician? I'm sure this question has any nurse working in the hospital, any healthcare. What is the risk to your family? And also the same thing if the family member has a history of cancer. What, if your family member is a doctor coming to home to this, what could be the risk? Anyone can answer. Aditya, madam.
Can I take this?
Yeah.
Please?
No, please. Because you're a pulmonologist.
So if I understand correctly, the person is a physician, I mean, is a healthcare worker?
Yeah, pulmonologist, nurse, doctor, anybody. Yeah.
Anybody, and they're coming home to and the family, one of the family members has cancer.
Cancer and those who don't, both questions.
Okay, so you definitely have to take your precautions as you're coming. Now, when I go to the hospital or the clinic or anywhere where I think there's a risk of me being exposed, I definitely, you're doing your regular PPE while you're at your workplace, and when you're coming home, you do have to take your precautions and have a shower and not touch anything and all those general precautions. And there definitely is going to be a risk, but then you do your regular cleanup, including your car keys, your coins, and anything and everything, because the fomites can still be there on the surfaces and on your body surface as well. The fomites actually, when they come into contact with any of the mucosal surface, that's when they're going to enter into your body and cause the infection. It may be nasal, maybe oral, maybe in the eyes, anywhere else. So there is definitely a risk, but you do have to take precautions. And if you're an active ER or an emergency ICU practitioner, seeing COVID positive patients, it's really important that you keep yourself, once you come home, you have your own space and you have your own bathroom and you're taking care of your laundry, you have your own utensils. I think that is really, really important till you know you're going to finish your shift for 7 nights or 7 days, whatever it is. And coming to immunocompromised patients, the best thing is to make sure if you cannot move them to your sibling's house or you cannot move them to another person's house, I think it's better they are in a different part of the section of the house, if that is possible, so they don't get exposed to you. They have a higher risk of contracting the COVID-19. So it's really important, if the best bet is, in case you know anybody who can take care of them for the next 1 week, 2 weeks, I think that's better you resituate them there. If that's not possible, they should be in a different part of the house. And you should isolate yourself to a different part of the house. Thank you.
Next question.
This is Sanjeev.
Go ahead.
Hello, this is Sanjeev Chopra. I just want to make one quick comment, and that is that in the home, when you're opening the fridge or you're opening the bathroom door or any door to go outside, use your non-dominant hand. Let's
Yes.
make it a practice. Because when we touch our face or we touch our nose, we are using our dominant hand. So just that simple tip may prevent infection.
Can I just one quick question, one quick thing which I have incorporated in my practice, like we do for our OR, when we go and change into my OR scrubs, I have implemented that to my office staff. We've got a side room where office staff come and wear their scrubs, do the work in the whole day, then go back and change into the regular home clothes and put their scrubs into a plastic bag, put it in the washer as soon as they get home.
Yeah, a lot of my physician friends have created a space in the garage, and when they come back from work after having seen patients, they strip there. They then put their clothes in a bag, take it straight, they wash their hands carefully, and then they go to the laundry and they do the laundry for those clothes. So that's another thing we can do even before we enter the house.
Yeah,
the
that's
other
what
couple
I've been doing, yeah.
One second, Ajay. Other two things is the ER doctor, Dr. Einstein, he isolate himself in a room in the house. And the other ER doctor in New Orleans, his wife and kids went to their house, their home house, and he's alone. So we'll go to the next question. This is very important. Walmart has implemented temperature checks on all their employees, whoever has 100 degrees or above. Should we implement all workers in essential services so they do not transmit the infection? The question here we're missing is, I'm making a point here is, this I'm going to add this question, I'm sure, please help anybody else. I just saw in Iceland, they did a whole survey of this whole community, 50% of COVID are asymptomatic. 50% of patients are asymptomatic. So I think Walmart checking temperature, we're missing a lot of them. We're meeting a lot of them. I think USA is not getting in the prevention like the Asian countries. And India just made yesterday, the WHO still does not want where everybody, all citizens should wear masks. And India go ahead and made their own change. In Japan, with 125 million people, only 1,600 COVID positive. Michigan, where I am, 9 million population, we have reached 9,000. So 1,000 positive COVID positive patient per million compared to 20 per million in Japan. We're talking about treatment, everything. I think we did not stop the. We're not educating. I think this is way behind. We're WHO 4 weeks behind. So does the whole America. So the next, this question also, there is another doctor asked me, I think it's cardiology, pulmonologist. Yeah, we have patients coming in, can we treat them? So Devta madam can help with this. The New England General Medicine said the virus is in the air an hour or two. And the question is, everybody, WHO says cough and sneezing. How about just talking? How much, when we talk, how much the air goes? Devta madam, can you add that?
Yes. I think if you look at the data which is from Singapore and Hong Kong, one of the things they strongly mention, as well as in Japan, one of the things they strongly mention is everybody wearing masks. They felt that even, as you said, asymptomatic patients probably, because the virus is found in the saliva. In fact, there is a study which shows that if you cannot get throat and nasopharyngeal secretions, they actually had people spit and the saliva is sent for PCR, and the saliva is also positive. So the virus is in the saliva. So they believe that the reason they were able to contain their COVID infection is because of everybody uniformly wearing masks, whether they are infected or non-infected, because we do not know how many are infected, and the infected ones are asymptomatic. And there is also a case report in China where they talked about a family of 9 in which 8 people got infected, and all 8 were non-asymptomatic. So there is transmission within the house, even if you're, so-called practice of hand washing. And I think, as you said, we are behind on this policy. I am not sure why we felt at that time, probably because of the fear of or the stigma of wearing, what shall I say, the mask, but we should do that. With the airborne, the question about airborne comes if you stay in the same room for several hours and then the airborne, what do you call that, inhaling it on a person who is symptomatic, it's airborne. It's 2 to 3 hours. So one of the advice is if you're home or if you're any places, open the window and ventilate very often. And in the hospitals, they have recirculation, so it may not be that bad. But home, you should probably try to ventilate with that. So my advice will be probably, I think Dr. Fauci has addressed that. He said that probably we should be thinking about the mask. I think he mentioned.
No, he's behind, madam.
He's behind? I thought he
Yeah, he's behind. So does WHO, does CDC. The next question is.
I would suggest that we probably should, as a AAPI with AMA.
Yeah, we did already send. They don't give us any value anyhow.
So maybe we should request all of these people to put a mask on everybody who comes in.
Yes, that's my question. This meeting, one take point. Please, 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 I beg you, don't see any patient without the mask. Dr. Einstein, he's on the front line. He's ER doctor. Do not see any patient without the mask on the face, please. Next question.
The patient should have the mask and the.
That's what I mean. Patient. Of course, doctors will have always, or healthcare workers. Next question. Any tips of extubation in COVID pneumonia patient, as we cannot use BiPAP, want to avoid reintubation, to Saraswati, madam?
So I think this is a great question, and it is a challenge for all the intensivists. Usually previously what we used to do is you extubate them. Of course, we have to look at the daily trials, make sure that lung capacity is good, and then extubate and transition them to a BiPAP. But now the BiPAP there is always a fear the BiPAP can cause this aerosolization, and it may contribute to the spread of the COVID-19. So one thing is, Rush is looking into this, the BiPAP, as I mentioned initially, BiPAP with a helmet mask, where it totally covers the face and reduces this aerosolization. And Chicago, Rush University, they are doing this. And in Boston, we are in the process of buying the helmet masks. We don't have them yet in all the places, main places, but we're in the process of getting them. So that's one thought process to from extubation, and if they need a helmet BiPAP mask, that's one way of doing it. The other way is making sure that they really recover, and they would not make sure that they don't need that ventilatory support, and then transition them. And aerosolize, even the high flow oxygen, here in our hospitals, we are not giving them more than 50 liters per minute of high flow oxygen. So we really not keen. We want to keep down the aerosolization and the spread of the COVID among these positive patients as almost to zero. That's the main thing here.
Seema, your next question.
Okay,
Thank you.
I have a question here about split ventilation. Any experience with split ventilation 2 on 1 vent? Is it FDA approved? And what are your experiences? Anybody from pulmonary or ID? Or Dr. Sanjeev Arora?
Seema, you said 2 patients on 1 ventilator, split ventilation?
Yeah.
Yes, split ventilation, we're not doing yet here. So, but I have seen studies where they're doing the split ventilation, and it is more cumbersome than what we think it could help. Instead of that, they're looking at a BiPAP with a helmet mask as an alternative when we really run out of the ventilators in Massachusetts. That's what we are looking at right now. So our experience in Massachusetts is kind of limited in the split ventilation yet.
I think
But rest of the world, I've seen papers where few of the hospitals, rest of the world, they are doing the split ventilation.
I think Seema, this is Sanjeev Arora, and split ventilation has many complexities, and it is clearly not as good as 1 ventilator per person, and it is probably never going to be used in the United States because of availability of relatively abundant ventilators compared to low-income countries. But it is being talked about right now, and people are preparing for that kind of situation in case the epidemic in low-income countries truly comes in at a massive scale. For example, as I mentioned, in Africa, you know, in the Southern Hemisphere, winter starts in June 21st, and if their public health system is not fully prepared, if that were to happen and their care system, that's when these kinds of technologies will have to be considered.
But New York has approved actually for split ventilation. I mean, it's not the most ideal thing actually, but for this situation, it is workable, and New York has, state has approved, the hospitals are using the split ventilators now.
Next question is, in these patients we have cytokine surge, IL-6 comes out. There's an anti-IL-6 called, I think, EOCILIZUMAB. Timing of use in patients with COVID heard when given at cytokine surge, positive results in 24 to 48 hours. Can you comment with anyone have experience?
So may I take this question, please?
Please, sir.
So the tocilizumab, it's hard even for me to say it right. It's a monoclonal antibody, and it's mainly, it attaches to the IL-6 receptors. And now with the COVID-19, we feel there's a surge of this IL-6 receptors, and it causes a cytokine storm or a cytokine release syndrome. And the main thing is we are using it at Tufts. Tufts has started using this. And you do have to be careful about reactivation of other respiratory infections, because you're giving this monoclonal antibody, and at the same time, you want to make sure that you're not reactivating other respiratory problems and other infections. And the other issue also is you have to keep a watch on the liver enzymes too with this. And it is an off-label use still. It's still experimental, but we are trying here in Massachusetts.
Okay, I have another question here.
Thank you.
The next question I have here is it okay to go on long walks? Should we be wearing cloth mask or surgical mask when we go out for a walk?
I think I'll take that one. You can go on a long walk because the atmospheric air, if there is any virus, gets diluted. But you need to be careful. Again, try to maintain distance from another person, the same about 6 or more than 6, minimum of 6 feet or up to 8 feet and beyond. And if there is a person who is, you think that there is a cough, please avoid them and go on the other side and go. I would suggest wearing a mask at this time for 2 reasons. One is, of course, as I said before, you may happen to meet people who might have cough or asymptomatic or things like that, and they may be close to you. Number 2 is also this is a season of pollen, and many people do get allergy, and then the time of confusion of the allergy and the cough, that becomes an issue. And this is cloth mask and the surgical mask. The difference is the filtration of the particles. And of course, the surgical mask does not even filter the virus. The virus is much smaller, but the droplets will be attached to the cloth mask, so the droplets will be okay. The surgical mask. The cloth mask seems to be one of the issue with that is the barrier for the wetness. You know, it probably will get wet immediately. It is possible that it will get attached to your face. So I'm not sure about the cloth mask. If you're planning to do a cloth mask, it should be a mask where there should be a moisture resistance. It should not be, it should not dry up. And of course, the weaving of the cloth is very different. So I don't understand how the cloth mask will work. It may work as a general barrier, but more as, I think, as a psychological issue. But there are no literature on cloth masks, so I think if at all you want, maybe very closely woven masks, which are used for other conditions in which people are like in OSHA related thing where people use paint and fumes and this kind. But they all seem to be N95 masks. So the cloth mask business, in my mind, is unscientific, unproven, psychological placebo.
Another question about community-acquired pneumonia. Outpatients, we are seeing a community-acquired pneumonia. What are the antibiotics of choice for those? And second question is multilobular pneumonia, but do not need to send the patient to hospital, stable vitals. What should we do? So Dr. Deepta, I think.
Can you hear me?
I think either the pulmonary or the private practitioners can take the one because they are the ones who deal with them all the time. It will be good for them to answer that one.
Saraswati, can you please answer that?
Sure. So the multilobar pneumonia, if it is a multilobar pneumonia, by then the person is already having hypoxia. I mean, that's really important to make sure that they don't have hypoxia. That's one of the main reasons. That is normally mild to moderate cases are around 80 to 83% among the big spectrum of COVID-19. The rest of the 13% of the patients are severe. That's when you have the hypoxemia. They can have lung failure at that time, hypoxic respiratory failure. They can go into those. Multilobar pneumonia is definitely warranting. They are an inpatient. It is not a treatable as an community acquired. It's not community acquired. And they need to be watched, making sure that they don't develop into an ARDS and a critical respiratory failure condition. That's the first and foremost. And if it is only community-acquired pneumonia, Seema, did you say, was the question positive for COVID-2 or no? The community-acquired pneumonia, did the patient is also positive for COVID-19 or not?
No. I don't think this is for COVID-19, just in general community-acquired pneumonia.
What is the treatment?
So if you see community-acquired pneumonia, what do? You send the patient for testing, or you just treat the patient like you would treat community-acquired pneumonia, or you would send everybody for testing in that case?
Every single patient, if they have every single patient, we should assume that every single patient could be having COVID-19 and they need to be tested before they can be called negative. Especially with community-acquired pneumonia, they must be having some symptoms, right? They'll have a fever, they'll have some kind of, they could have increased respiratory rate, they could have cough, they could have shortness of breath, or if they have a pulse oximeter at home, then they might be hypoxic too. Low saturations also might be there. So they need COVID testing definitely. And they would definitely need an evaluation, as in going to the hospital and getting evaluated. Though it's community-acquired pneumonia, we cannot take it, in this pandemic, we cannot take it lightly because they can have other complications also, respiratory complications. So usually what we used to do before, we test for influenza A, B, and the respiratory syncytial virus with the help of a nasal swab, but we don't do it anymore. We just go ahead and straight away test them for the COVID-19. And of course, we are getting a chest X-ray too. And we are measuring other parameters as well. And the blood count, which includes the lymphopenia, they could be having high D dimers and abnormal LDH. So these are other CRP, procalcitonin. They could have all these other abnormal blood work too. So yes, they need COVID-19 testing.
Next question is also, there are two questions. One about helmet mask, which minimizes air leak. The other question is, how about a non-breather mask for Dr. Saraswati?
So the helmet, non-rebreather mask for treating COVID-19 patients on the long term?
They just mentioned solid. Now, how about a non-breather mask, or what about helmet mask, which minimize air leak? Maybe they mean in acute case, but I don't think that.
So the helmet mask, this actually covers the whole head, and it causes a little bit like a negative pressure. So that way the aerosolization, what we fear most with the BiPAP is the aerosolization. So that the helmet mask prevents that. So that's one part. And the second one was non-rebreather. So I've seen some small papers and literature on if you don't have a ventilator and they don't have anything else at that point, right? They intubate the patient and then they just do the ambu bagging. I've seen, like, when they're short of ventilators, I've seen something, some literature from Italy. It's so hard. But the non-rebreather bags, they're not going to work in the long term. It may be for a short term till you get a real set of intubation and ventilators ready.
There's a question about if you're 70-year-old male or female going to post office, park, grocery store, how much care you need to follow. You have to follow 70. Average, high risk is, I can mention that high risk age, obesity, hypoventilation, sleep apnea, it goes on. You have to take extreme care when you go out. We might have a next question.
Next question is, there is a COVID-19 positive person at home. What should be the precautions for other people? Do you need to just separate them out in a room, or the patient should be quarantined outside, or should you just take it for granted that everybody in the house has COVID-19, or all have to be have to be quarantined?
I'll take the question. If you have a COVID-19 positive patient, so I want to just define the term as what is a quarantine and isolation. Quarantine is when you do not know the sero status of a person. So that's a general term. Technically now we are all at this point when we say stay at home, we are putting ourselves in quarantine. Isolation is when you have a positive infection and then you isolate yourself. So COVID-19 positive person, it should be on isolation. That means the person should be in a room with their own bathroom, and that person should be cleaning their own clothes, washing their clothes. The food should be given to that person outside. That person should not have contact with anybody for 14 days. That is isolation, because you do not know what will happen to they are infected. Usually after 4 to 5 days, they might have symptoms, and then you need to follow from then on as to, you can have a video conferencing with a doctor or a teleconference to see how the symptoms progress. If they don't progress, they can continue, they can have maybe Tylenol or whatever is necessary, but that person does not come out of the room. That is isolation for a positive person. If there is a positive person in the house, the chances are there are going to be other positive people. The so-called ROV, which is the infectivity rate for COVID virus, is between 1.5 to 2. That is, a person immediately within that infection, within that area will infect 1 to 2%. And for every COVID patient, if they move around the community, they will be infecting 10 people. So if you have one person positive in the house, all of the others need to be tested, because as I said, in that family in the China, out of the 9, 8 were positive. So you're going to have others positive. And each one will have to then take precautions and follow up with how they're going to do. And it is going to be difficult. Most of us live in a family of, 1 or 2, and then maybe 2 children. And it is going to be difficult how to isolate them, things like that. As before, Dr. Lokesh said, the priority is get the old people out or put them somewhere else. But they have to be isolated. That is the word you have to. They are not quarantined. They are isolated. Isolation is exactly what we do in a hospital. They have to be in a separate place.
Yeah. Next, how do you disinfect regular surgical masks or non-medical general population? There's one more question they asked: if general population, if they don't have N95, what kind of mask. I think just looked at the Korea. There's even the Indian one. There are 3 layers. One is cotton, maybe flannel on the back. In the middle, they're putting these HEPA filters or even vacuum bags. Something you can look in the different website will find. How to disinfect? Anyone can answer any disinfection of regular surgical mask, or they're not supposed to, non-medical general.
Regular surgical masks cannot be disinfected. They are used only once, but your N95 mask can be disinfected. There is a protocol available by putting them on the way of either through the ultraviolet, and there's another disinfection method. I think University of Minnesota has that protocol. You can probably look it up. And this is something new. We never used to use N95 mask. We used the mask for more than 1 day. We used to be given to one person, and it used to be on the ante-room as an isolation person. That is the way we used N95 mask, usually in the area of mycobacterial diseases. So this is some completely different area we are looking at, but looks like it is effective and it can be used, and you can look at the protocol.
Other question, any predictors who will do poorly, like, hand health do well, any other warning signs like, example, IL-6, ferritin, or anything else? Anyone can answer.
So the blood work, yesterday I was having a discussion with one of the chiefs here for ICU, where I wanted to find out if there was a trend, like the D-dimer is so high, if it's more than 3,000 or whatever number, is there a correlation, and the procalcitonin. So I've seen a small paper which said about the procalcitonin and the D-dimer. If it's very high, then the criticality of the patient could be high as well. But so far, it's such an evolving thing that we don't have concrete evidence yet. But that's one of the thought process between the procalcitonin and the D-dimer levels. That's one thing. And the higher oxygen numbers they need, and more support they need, if they're on pressors, vasopressors in the ICU, if they've already gone into, from ARDS, they've already gone into multi-organ dysfunction syndrome, then the criticality is more as well. So these are some of the things in an ICU setting that we look for. And we also want to make sure that they're improving, their oxygen numbers, the dependency on oxygen is coming down. And so that way we see signs of improvement. And I think the blood work will also help in trending it low. So we see a trend if the procalcitonin and the D-dimer levels are coming down, that would be another indication that they're getting better. And that's my thought. Thank you.
Another question I have here is COVID-19 virus excreted in the urine. How long is it? And also somebody else asked, how long will be in the feces?
COVID-19 is found in the fecal. It is cultured from the feces, and it is found there is probably some amount of oral fecal transmission. We have not proven that, because since it is also present in the nasopharyngeal passages and respiratory secretion, it's hard to prove it, but it is excreted in the feces. What is the other one? Question, sir?
Urine and fecal, urine.
Urine, we do not have, urine, it's not present in the urine, and it is present in the feces. It's present in the blood also, but in much smaller quantity. And, you know, as far as I know, we have not, what shall I say, guidelines do not talk about blood-borne pathogen like in HIV, and the infectivity of the COVID virus from the urine, from the blood. We have no, at this point, any, what shall I say, any circumstances where we can prove that. It is possible that if people have donated blood, asymptomatic people donating blood, maybe we will see something later on, or maybe somebody will catch it because it is circulating in blood. Very small quantity compared to the respiratory tract.
Next question, how can you ask about hazard insurance for healthcare workers? Are we lobbying for this? Anyone can answer.
So I called my insurance company a few weeks ago, my malpractice insurance company, and because I do work in the hospital as well. So they told me that they checked back and they said with Coverys and other big companies here, they said it is included. COVID-19 is included, and they also said that the televisits and telemedicine are included in my current malpractice insurance, and I do not need to take anything additional. That's my understanding, my personal experience.
Seema, you have a question?
Next question I have is it appropriate to treat my patient with COVID-19 with fevers and immune compromised status due to being on Humira for Crohn's with hydroxychloroquine and Z-Pak on outpatient basis since he is not sick enough for hospitalization? I think Dr. Deepta.
Okay, I'm going to give you the information on hydroxychloroquine. Hydroxychloroquine was initially thought as a malarial drug. It was used at the time of SARS-CoV-1, and it did not improve that. So from somewhere along the line, it was used in chikungunya, and it actually caused a paradoxical effect in chikungunya and in humans, and it worsened the recovery of chikungunya and left them with more complications. At this point, people are all using hydroxychloroquine, and the animal models show that hydroxychloroquine, it caused more damage to the animals in certain animal models. And the scientific advice is do not use hydroxychloroquine without registering them in a trial. And hydroxychloroquine and azithromycin both cause QT prolongation. So it will be very dangerous in a patient to use hydroxychloroquine and azithromycin as a combination. So I probably will advise against it. And if you want to use hydroxychloroquine, please call any of the universities, and they are taking patients, and you can enroll them and they will follow them up.
Next question is, how will it affect a person with high IgE, low IgM with diabetes? Again, Dr. Deepta.
Diabetes is because it's diabetes by itself is an immunocompromised status where the T lymphocytes don't work, and the response with the humoral antibody response with the antibody formation of B cells don't work. That is probably one of the reasons. Of course, there are atherosclerotic heart disease which goes along with that, etc. The other one, IgE and IgM deficiency. IgE deficiency probably will not interfere with infection of the COVID. I am not sure about IgM deficiency because I have no experience at all with IgM deficiency. Most of us have dealt with only chronic IgG deficiency. So I have no experience with IgM deficiency, so I cannot talk about that. There's probably some immunologist who is listening might be able to give some information on that.
Lokesh, do you have any other questions?
Yeah, could you please ask panel stable asymptomatic multiple myeloma patient on maintenance therapy? Should they stop it until COVID-19 is started out? I don't know if we have any oncologists.
Yes. Can I answer this?
Yeah, please, anyone.
So it's a multiple myeloma patient, and they're on medication?
They're stable. This what it is. They are stable.
Okay, stable, but whether they should stop taking their medications?
Actually, maintenance therapy. Should they stop maintenance therapy until COVID-19 is sorted, or continue the maintenance therapy? But
it's really, I think what we need to understand is it's really, really important for us to take care of our own comorbid conditions. Optimize the treatment on taking care of our own comorbid conditions. Let it be diabetes, let it be COPD, let it be anything, or even multiple myeloma. If they are on if they are on medication, they should continue that. The best thing is the prevention, taking precautions of regular hand washing, social distancing, and staying at home. Those are the precautions that they would need to take. They have to be extra cautious. I do want to touch base on one thing regarding the fecal-oral transmission. I've read literature and it said even the toilet, when you're flushing the toilet, it's really important to cover the lid of the toilet, mainly because there is a thought process that the airborne particles can float around, and it's really important that you don't spread it in your bathroom. So it was that article suggested that we close the lid of the toilet when you're flushing it, and also making sure that you clean your bathroom sinks and everything. I thought I'll just share this piece of information. Thank you.
I think Umar Janalgad asking, Dipta madam, you have 38 years of experience here. You see your mentor, Dr. Fauci. Can you advise him about for the nation? She can be an advisor. He could be advising him in the recommendations, which are the gaps.
Absolutely. You know what I would do is, I'm a alumni of Downstate Medical Center, and Dr. Sheldon Landesman, my professor, he has worked in NIH with Fauci, and as you all aware, Fauci is from Brooklyn, so he has come and met with us. So I am going to ask my group, and we'll all get together and write a letter to him as soon as possible, maybe in 1 or 2 days, because it is of the professional group feels at this point that the mask is important for general public. So I will speak to Dr. Michael Morgan-Braun, who is the chairman of the Department of ID in Downstate, where I am from, and I will definitely follow through and send a letter from that group to Dr. Fauci.
Yeah, okay.
Next question I have is, why are young people getting infected so badly that they are being admitted and at risk of being intubated and dying when they have no underlying medical problems? And following that I have, and why is there such a huge disparity between getting a milder infection and being deathly ill in the hospital? What's the middle ground? Anybody can take that.
I can give you the statistics of it. By looking at the Wuhan experience, the people who have had death is predominantly male and or multi-organ or multiple organs involvement of the previous condition, and that is chronic condition. And also the older women, that seems to be the group. And I think the underlying cause is probably the reason for the progression of the disease to the ARDS and death. The reason being that whatever the underlying cause is, it is unable to tolerate the hypoxia and the cytokine surge which is happening. That is because, as I said, there is a tremendous suppression of all your T cell functions. Because as you are aware, in infection of a viral infection, the T cells are the ones which give you protection. There is absolutely no protection in this particular viral disease because humans are naive to the virus. We have not developed any kind of antibody. So this is one of the reasons why this is high. And I think the younger generation, you're all aware that as you are older, 60 and above, the T cell deficiency continues. And it's a natural for depression of T cells. So with that and the underlying cause, that is probably which is causing for the older people.
Risk of traveling in elevator. Dr. Kasani from is cardiologist from Yan asking risk of traveling in elevator. Hello.
I will give you the guidelines for traveling in elevators. The guideline is if the travel is, if the elevator is about usually 6 by 6, usually the about 4 by 4 is a normal elevator, and it can hold 2 people if they are not coughing. That is what they are suggesting for a space. So that is what it is. If somebody is coughing, it is you should not be getting into the elevator. The person who's coughing should probably travel alone, and touching the panel and touching the sides all should be avoided. You should use your elbow or you should use your knuckles to press the buttons, and preferably have antiseptic wipe to wipe that area prior to pressing with your knuckle and with your elbow.
So 2 people and 6 people elevator. Okay. How about mass transit? Traveling.
I don't have any guidelines because I think it is
Too risky. Okay.
6 feet apart?
Yeah, but transit is not going to happen. So does India. And MIT, there's a recent article from MIT that virus can spread 27 feet. I don't think it is true, but madam.
You know, but there is also a thought process. By the time it reaches 27 feet, I think it becomes inactive. So that's another thing we need to think about as well. So I just wanted to answer Seema's second part of the question regarding the mortality in may I, please?
Yeah, please.
Sure. So the global death rate is anywhere from 2.5 to around 5%. But in Italy, actually, the global death rate is higher. It's close to 9.5 to 10%. And they found that cigarette smoking was one huge contributory factor for the increase, for adding on to the comorbid status and to the death rate as well. And so in males, it was around 11%, and they found that 60% of the men were smokers in this particular study. And then the females, the death rate was around 6%, and the cigarette smoking status was 30% in the women. So 30% of them were cigarette smokers, and the death rate was 6% in the females. So that's something to keep in mind about when we're talking about these comorbidities and the criticality of these patients.
I think one question, maybe Suresh, if he's here, what can we, or AAPI, anybody doing to India? Are we doing anything to India for anybody in the panel?
Thank you. Can you hear me?
Yeah.
So at this point, we have several of the Indian media had reached out to us. Right now, they are looking up to US for getting the know-how for advanced medical treatment. India is still in the initial stages of the curve. As of now, actually, they are doing a great job as showing their discipline for social distancing and wearing masks, and managing a country like India is, you know how difficult it is. But I think they are doing a great job. They are still in the initial phases, and luckily for some reason, I don't know if there are various theories they are suggesting, that maybe the temperature or the immunity. But coming to what we are doing for India, at this point, some of our local chapters have raised some money to buy some protective equipment for hospitals in India, like the Tennessee chapter, one of our alumni chapter, they donated some masks to our alumni hospital in India. That is a designated COVID. It's a Gandhi hospital. So nothing major at this point, because the way it looks like, the way we are already like overwhelmed with the work here itself. I don't know if we can do anything to India at this point, but at some point, yes. But once we have a control here, we are raising a lot of donations and funds, and we are trying to donate masks. Maybe we already got some masks to donate to the hospitals here in New York, New Jersey, and also in Chicago. We'll be giving next week. I think we want to take care of the home here first. Then maybe we'll put another donation box on our website to be donated to Indian causes. A lot of philanthropies in India also came forward to give money to the Prime Minister Relief Fund and the CM Relief Fund. At some point, yes, AAPI will be, soon we'll open up a box on our website. Who wants to donate to India, they can donate through AAPI, and we'll release checks to the PM and CM relief funds.
Okay, next question.
Thank you.
We have collaborated with ECHO project, so maybe we can work together with Dr. Sanjeev Arora and do something because we're doing a lot of work in India, I guess.
And we have maximum 10 more minutes. We're already here 1 hour, 20 minutes. Oh, actually, yeah. One question, men versus women, morbidity higher. I think the studies from Wuhan showing 2/3 of the people who die is men. I will follow Michigan data, which is similar. But the caller here, the question is in San Antonio, they say 5 out of the 6 deaths are women. Anyone can comment on this?
I think it's an isolated incident. I think it's need to look at what is the population in that area. And also, as you know, that women outlive men in the older age group. San Antonio could be one of those retirement communities, and it's possible there are more women population than men in these retirement areas. So I think we need to look at the numbers and see where it comes from, because this seems to be an isolated statistics compared to the rest of the what we have seen.
Any other questions?
No, I don't have any other questions.
I can ask. Go ahead.
I just want to mention one thing about one of the callers who talked about the what are the laboratory numbers which may be predictive of progressive disease. LDH also seems to be one of them, as we are all aware that we used to look at LDH in PCP pneumonia because it also gives you ground glass appearance and interstitial pneumonia and diffuse alveolar destruction. So one of the studies in Wuhan says that following LDH will also give you the early markers of progressive lung disease. And the reason I mention it, if you look at your panels which you order, LDH is not usually in the panel, but the LDH should be added. If you add LDH, it's elevated, then you know that's probably lung inflammation, and then you can follow that to see how they go.
Okay. Sima, can you ask closing comments from the speakers?
Okay, so do you want to say the closing comments?
Each speaker ask, each one.
All right, so I would like to thank all the speakers. Would you like to say a few words in the closing, Dr. Saraswati Mupama? Saraswati? Dr. Saraswati?
Sorry, can you hear me? I was on mute.
Yeah.
Can you hear me?
Yes.
So I also wanted add about the cleaning of the masks. So usually for the CPAP masks, those are different, of course. We use something called the ozone technology, but the cleaning of these surgical masks and N95s, they're trying something called the UV technology. There's still a lot of speculation going on about that, but that's something we have to keep in mind also. That's one thing I wanted to say. And I really thank AAPI and Dr. Suresh Reddy, Dr. Seema Arora, and Dr. Adara for giving me this opportunity and share my thoughts, and I hope it was helpful. And please be safe. Please be regular hand washing and social distancing. Please stay at home, and please reach out to all your family members. I keep half an hour a day to reach out to all my friends and family, just to show them that I'm there for them, and it's a great support for me as well, and they do the same for me too. So I think this is really important. We're all in this together, and let's beat this virus.
Thank you. Thank you, Dr. Saraswati. Dr. Dhruv Shah, would you like to say a few closing remarks? Dr. Dhruv Shah, are you still there?
Yeah, I'm here. Can you? No, I just want to say thank you all for putting so much effort and time into everything what you do every day. For those of you who are interested in learning more, I think the best thing I've learned today is from Dr. Chopra. the true nation is the nation of humanity. And I think we clinicians are coming together to not only save the healthcare system, but I think as a society, we are all contributing towards our neighborhood, our community, our state. And as Dr. Reddy mentioned, we are taking care of our home as much as India is our home. I think this has really made us vulnerable. But at the same time, we are all so motivated that we would be working on this together. If anyone is interested in learning more, please go to AAPI website or any of the other resources I shared. And then stay well and stay healthy. Good night.
Thank you. Dr. Sanjeev Arora, could you please say a few words?
Sure. Thank you, Seema. Thank you, Dr. Suresh Reddy, for the opportunity to join this important call. All I would say is that when AAPI, we are grateful to have a partnership with AAPI on the ECHO project. And whenever AAPI is ready to use some of its expertise to help India, I think the problem in India is escalating despite the fact that the summer is coming. Just I think in the last day or two, for example, from April 1st, they had 396 new cases. And so I think they need the expertise of AAPI and the resources, and we are ready to partner with AAPI for amplifying both the public health response in India and also the care response by training doctors. And some of the kinds of lessons we learned today would be very useful for doctors in India also. And we've already trained 80,000 of them, but as you all know, it's a really, really large country, and we need to have a very broad scale attack if we are going to make a big difference in India. Anyway, thank you again for this opportunity.
Excellent. Thank you, Dr. Sanjeev Arora. Dr. Amit Chakravarti, would you like to say a few words?
No, thank you. It was a very enlightening. I mean, as usual, all the teleconferences have been very good. Thank you, Suresh, Seema, and Lokesh for doing this. My part of the topic was basically financial survival. And if you want to learn more, like I said, it is there in the blog on my website. Please go and visit that. Those are the people who actually are not, we were not represented on the speaker panel. People like us who are in private practice, but that's a very, very important thing whether we close the practice and do stuff do stuff where we can survive this onslaught and come out of it. And there are various ways that the government is really going, unprecedented ways where they're going out to help you, like the PPP. You can actually get money from the bank, and that is absolutely going to be forgiven if you pay your employees for 2 months. That's an amazing step which we have got, and everybody should apply for that. And obviously, there's a disaster loan. Who are not in private practice, they can apply for that. So all those things are there on the blog. Please, and it's been out of the whole maze of information. I've just tried to select the stuff which is important for private practicing physicians. And please have a look at it, amitaapi.com, and you can go to the blog site. Thank you very much for allowing me to present my part of the talk. Thank you so much.
Thank you, Dr. Amit Chakravarti. And Dr. Sanjeev Chopra, would you like to say a few words? Dr. Chopra, are you there on the call?
Maybe muted. So one last question, Seema, before we go deeper. The question is, are we seeing the incidence of COVID-19 in Indian American population? Answer is yes. I think anyone on the panel can comment. Second question is, one family husband is in ICU intubated, grandfather died already, and all the family members are isolated. This family was going to Costco, post office, grocery store, etc. This is an Indian family. This is from Dr. Ajay Agrawal. I will add that even we saw the African American people, yes, they are affected too. I talked to one of our friends in Georgia, and it's comorbids are same as anybody else. Dr. Deepta, madam, can you elaborate and close the comments from you?
I think as you mentioned, Dr. Idra, This virus does not care about what status you're in, what skin color you're in, what country it comes from. All it needs is a person to cling on to. So I think it is really humbles us to see such a universally infecting agent. Number two, as you also said, please, both the physicians' families, and the physicians should educate everyone. As you do a teleconference, please tell them about having social distancing. Do not leave the house unless it is necessary. And if it's need to be, it's one designated person who have to take the infection precautions. This is the time the society needs to come each other. You can have a call system. If somebody goes to the store, they can pick up and deliver. And the only way we can flatten the curve and bring down the disease is to not infect any more people. So everybody should consider themselves as it is infected and try to follow the rules we have. There is no exception. There is no reason for 10 people to go to Costco. We all have delivery systems. Please educate your patients. I think that is one. And please support all of your fellow physicians. Give them a call. Tell all your retired doctors to call and talk to everybody, give them a moral support, and help them go through this process by any way, which way we can help. Thank you.
Thank you, Dr. Deepta. Is Dr. Sanjeev Chopra here, or he left?
Yeah, you can close.
Anyway, Dr. Deepta, closing remarks from you?
I just finished my closing remarks here. I gave it to you.
Okay. So, Lokesh, can you please say the closing remarks and we'll end the call?
Sure. Thank you so much. Today, I think more than 200 people attended, and we'll keep continue giving information. And please take care, everybody. Thank you. Good night.
Thank you. Good night.
Thank you, everyone. Stay safe.
Thank you very much.